shower and note to get going. So as you just heard, we're going to start recording today's session. Please mute yourself during the webinar and also feel free to put your questions in the chat as we go. We'll keep them for the end during our Q&A time. We're really excited to be kicking off this year's quarterly webinar series on a timely topic of NRT in youth. The title for today is Beyond the Patch, Supporting Youth Through Evidence-Based Nicotine Cessation with our honored guest, Dr. Kevin Simon from Boston Children's Hospital, and he's highly experienced in this subject. We're looking forward to some other provider webinars this year, including October's session on cancer patients and cessation, co-hosted with BC Cancer and highlighting their NRT pilot in Prince George. And then we'll have November's session on the intersection between radon exposure and tobacco cessation with Dr. David McVia from BC CDC. And then January session on pregnant people and cessation led by Dr. Nancy Poole, who's the president at Center of Excellence for Women's Health. Please sign up for our provider newsletter. We'll send the link shortly so that you can learn more about these upcoming webinars as well as the latest research in tobacco cessation. So this is just a brief agenda for today. We'll be going over a land acknowledgement, brief introductions, the presentation by Dr. Simon, and then a time for Q&A at the end. And our land acknowledgement is, Quit now serves the entire province of British Columbia, spanning lands built on a complex history of colonization. These lands have belonged to diverse First Nations, Métis, and Inuit communities since time immemorial. We are grateful for the privilege to work, live, and play on these lands. And if you feel comfortable doing so, please put in the chat today where you're calling in from. I'm just going to briefly introduce myself. I'm Beth Clark. I manage the coaching and outreach services at Quit Now, and I have over 5 years experience in health promotion, starting first as a health coach and then receiving my master's in public health at Simon Fraser University. I'm a settler to Canada of European descent, and I live in what's known today as Burnaby. And then we're so grateful to be hosting Dr. Kevin Simon today. He is the inaugural Chief Behavioral Health Officer for the City of Boston, appointed by Mayor Michelle Wu to lead citywide behavioral health strategy through the Boston Public Health Commission. As a triple board certified psychiatrist in child and adolescent psychiatry, adult psychiatry, and addiction medicine, he brings a systems-focused, equity-driven approach to public health and clinical care. Clinically, he directs the Justice Clinic at Boston Children's Hospital, where he cares for youth facing the intersecting challenges of mental health, mental illness, substance use, and system involvement. Academically, he also serves as an assistant professor of psychiatry at Harvard Medical School. His research on structural violence, youth well-being, and behavioral health equity has been nationally recognized. His work is published in notable journals such as the New England Journal of Medicine. Dr. Simon is a sought-after thought leader and a voice on mental health in both academic and national media platforms. With that, I give a warm welcome to Dr. Simon, and we'll hand over the mic to him so he can start sharing his slides.
Well, thank you for the introduction, Beth, and I will share. Yep. In the event you can't see my slide, obviously, yell, shout, tell me. As Beth noted, I'm Dr. Simon, Chief Behavioral Health Officer for the City of Boston, pediatric addiction psychiatrist at Children's, assistant professor, and we will be engaged for the next 50 so minutes. By the end of today, hopefully, or it's my hope that you should be able to explain why addressing nicotine use in youth is urgent, summarize some of the best evidence that we have in terms of randomized controlled trials, looking at NRT and pharmacomanagement in terms of replacing that for kids who are using substances like nicotine. Consider practical prescribing tips, being able to think about motivational interviewing and potentially using those skills in your engagements with young people. We're also going to take an opportunity to appreciate lived experience through a mother's note, and then hopefully have time for some question and answers. And so let's move forward. In terms of the clinical rationale, right, we should always start with the why something matters, because if we aren't really clear of our why, then the how then doesn't matter. And so why should we be thinking about and addressing nicotine use? So trends in the US, youth e-cigarettes from 2011 to 2024, and I'm gonna use my laser here. So we actually can see that in 2011, just about 1.5 US high school students reported vaping. But then by 2019, that number jumped up to 27.5, which is more than 1 in 4 high school students. Now, during the pandemic here, it highlights that data collection had to shift, which is true. But post-pandemic, if we even want to call this post-pandemic, but after since 2021, there is an acknowledgement that there's been a decline in e-cigarette use. However, the decline doesn't mean a disappearance. And so even at these lower numbers, vaping still remains a major public health concern. In part, this 7.8 is still well higher than the 1.5 back in 2011. And it's not just an abstract percentage. That 7% is about 1.6 million youth currently using e-cigarettes or vaping devices. So again, that's still more than 1 in 4 that sustained nicotine, in essence, dependence, and not just some casual experimentation. Most are using disposable products like Elk Bar, Breeze, Mr. Fog. So 8 out of 10 actually use flavored products, often fruit or candy flavor, and more than half of the young people prefer quote unquote ice flavor that actually combines fruit and menthol. So the flavors in disposables are not just an accident. They tend to, from our opinion, to be a deliberate design to attract the attention of young people. Thinking about, again, why should we be addressing this? Looking at nicotine dependence can occur, health effects, and is there actual transition to smoking that occurs? So we'll answer these questions over the course of this presentation. Thinking about nicotine dependence. So nicotine itself acts on our nicotinic cholinergic receptor, and it ends up triggering the release of a neurotransmitter that produces a psychoactive response, or i.e. a reward, where it feels good, dopamine. And so with repeated exposure, what ends up happening is that tolerance will eventually develop. And so the effect that the young person might be seeking, they need to either use a higher concentration. And so what ends up happening is they tend to shift the kind of frequency that they're engaging with the e-cigarette or vaping device, and or changing the product. And so if we follow this diagram, right? So tobacco product, environmental influences, i.e. peers, local market, basically how can they get access to it? The smoking or vaping behavior occurs, nicotine enters the body, yes, it goes to nicotinic cholinergic receptor. And there are many factors here, right? Age, sex, genetic predisposition, because we are aware that there are predispositions for persons developing nicotine or tobacco use disorder. Is it that they already had a psychiatric condition, or were they going to develop a psychiatric condition, be that ADHD, generalized anxiety, or otherwise? And or did they potentially have risks related to substance use? And so the neurotransmitter, again, that gets released is dopamine. And eventually there's a cap on how much dopamine at least nicotine can provide. And so there are these reinforcements of temporary enhanced performance, some mood modulation, lower weight because it's an appetite suppressant. But then the challenge is the nicotine is short-lived. So then you're going to end up having reversal withdrawal symptoms. So this withdrawal symptoms, irritability, mood, fluctuation, those will happen. And so then this notion in the past of self-medication, it perpetuates this cycle. And unfortunately, young people are not necessarily aware that this is happening to them. So when we think about the neurotransmitter, and this is a cross section of the brain, we're aware that dopamine in the young person or even in adults, it is online before our prefrontal cortex, or if we put our hand over our forehead, is online. So when you get introduced to things that accelerate your dopamine feeling too early, unfortunately, that can take hold of or rewire. And so your prefrontal cortex, the thing that enables us to have that executive functioning, when it's not online, and so if you have a 12-year-old or a 13-year-old or a 15-year-old, and they've been exposed to nicotine via vaping, unfortunately, it can then skew those normative expectations that we have, like delayed gratification, or it might be much more difficult for that parent or guardian to make suggestions of why you should be doing things that will have later good effects on you, because they've been introduced so early to substances. And so I know I was referencing dopamine. I'd like to present what it looks like for natural dopamine levels to look like, and then what it looks like for those who are engaging with nicotine vape. So in the normal, all of us, we like food. And so a good meal can bring our dopamine to, let's just say 150, right? And so if I were to call folks out, I might ask, hey, what's your favorite meal? And I can speak for myself. I like Italian, Chinese, American burger. And so I probably get to 150. We eat that meal, we feel satiated. And that duration of time of the meal lasting is about 30 minutes post swallow, right? And intimacy, something that many people will experience, whether independently or with a partner, that achievement of quote unquote climax, that gets dopamine to about 200, right? So again, food, a good meal, 150, intimacy, climax, 200. So now the question is, well, what does dopamine from a nicotine vape look like, or from a cigarette? This is where the evidence was coming from. So nicotine, so inhaled very quickly, it gets to about 225. And so it's important to think about this, particularly in the context of a young child who normal things that can bring them joy, playing with friends, being at the park, potentially even playing video games. It'd be more aligned with the food. And so now to introduce something like a vape or e-cigarette, and within seconds, right? Because even a meal requires preparation, requires a parent to cook, requires to even drive to the store. That takes time. There's a buildup. The vape device or cigarette that's in your palm of your hand, within seconds, literally, the inhalation comes, and then nicotine is already in the brain, and you're at 225. And this duration of time is actually on about 15 minutes. And so what ends up happening is a lot of times, so in the past, the concept of chain smoking, individuals who are utilizing multiple cigarettes in a row, we recognize that most youth don't just utilize vape, one puff, and then put it away. It's more likely that they're engaging with the vaping paradigm over the course of a couple of minutes, and then what's going to happen to them is each puff does not bring you to 225. And so what if you talk to kids, or talk to young people, you'll hear them acknowledge that yes, they hit their vape a few times, but then they have to actually kind of quote unquote put it aside, put it in their pocket to enable the dopamine to come back down. Otherwise, they keep hitting a plateau, and they like the quote unquote nic fix that they get. Um, but again, getting introduced to this in the adolescent age range before our prefrontal cortex is fully developed, it begets challenges because now things like again attention become even more problematic, and so is the person potentially developing an intentional challenge because nicotine, again, it is a stimulant. And so is it that they have ADHD potentially, or is it that they are having a challenge just again with nicotine use? And so it's important to be cognizant of this when you engage with your patients and their families, because you want to explain what it is, not just negatively that's occurring, but how it can also make it confusing to attempt to try to diagnose conditions that do have treatments out there. So this is dopamine. In reference to other challenges that happen, right? And so there's just an image of pictorial image of kids engaging in the vape. There are respiratory challenges, right? And so coughing, it's not uncommon that I engage with a young person, and literally while we're engaging, whether it's in person or virtually, they are actively coughing. And they'll bring up the idea that, they have a cough because of a cold. And yet it's like, well, there's no other symptoms that you're having to relate to the cold. So there's a chronic cough that can occur. Hypertension, right? So anytime that you're utilizing a stimulant that can increase your blood pressure, can increase your heart rate. Again, the attentional challenge is because nicotine itself is a stimulant. And so if you're using that regularly, there's momentary increase tension, but then anytime that you then don't have that, the nicotine withdrawal effects are going to occur, such as irritability, mood changes, difficulty sleeping. And so what can start off as intermittent engagement with nicotine can end up turning into kind of chronic engagement with nicotine, because nobody actually wants to feel irritable or have their mood change in a negative way or have difficulty sleeping. Those aren't things that I think any young person or any adult wants to feel. And so what ends up happening is that that young person may then keep re-engaging. Again, it goes back to that earlier pictorial, re-engaging with it because they think, oh, I feel less anxious when I'm engaging the vaping device, not recognizing that it's actually perpetuating the anxiety. And so these are things to keep in mind when engaging the young person around the psychoeducation of what it is that's happening to them physiologically and psychologically when they're engaging in nicotine. So again, in terms of why address this, so a question is, does vaping lead to smoking cigarettes? And it is an active question we're looking at in the research. And so what I want to highlight here is going to be a chart that shows up. And so this graphic is showing us several different studies that are all asking the same question. If someone uses e-cigarettes, how much more likely are they to go on to smoke regular cigarettes? So that's the question that each of these studies is asking. And so I want to organize this for us. So each horizontal line is a study. So each one of these, 1, 2, 3, 4, 5, 6, 7 are studies. So each horizontal line is one study, and then each square, so square, represents the best estimate from that particular study. And so the line then stretching out from the box indicates the result of the possible ranges for the result of that particular study. And bigger squares implies that the study had more influence on the overall result of the 7. So there are 1, 2, 3, 4. 4 of the 7 really are influencing the major result. And so when you combine, or when we combine all of these studies together, this is what helps us get this diamond. And so when we combine all the studies together, that's what the diamond is here. And the answer is clear. Again, the question was, does using e-cigarettes lead to traditional smoking? The answer is clear. Yes, it does. And people who use e-cigarettes are more than likely 3.8 times, or you could say 4 times as likely to start smoking regular cigarettes compared to those who don't. And so when a parent asks you, or maybe a young person might ask you, you can't say definitively that yes, there have been analyses to look at this exact question, and it is overwhelmingly that yes, that is true. Another way to frame this to a parent, I don't have a coin on me, but if you had a coin, a quarter, and you flipped it, for those who do not use a vape, you'd have to get a heads 4 times in a row on a flip of a coin, four times in a row. It's pretty unlikely that you're going to get a heads 4 flips in a row. Whereas if you do engage in a vape, so again, if you do engage in vaping, you need to just get the heads on 1 flip, right? That's much more likely and much more challenging because it's just 1 flip that I need to get a heads versus the non-vaping, I need to get 4 heads in a row on that same coin flip. So it really is risky for young people to be engaging with vapes because it is more likely to eventually engage in traditional cigarette smoking. And here I'll also highlight, because the question might come up, well, isn't e-cigarette use or vaping safer than traditional cigarettes? The studies that demonstrate that were done in adults who had a long history of traditional cigarette smoking. And so that is not the same population as those who are young, should be healthy, should have healthy lungs. The fact that they're engaging with e-cigarettes, it implies, or it should imply, no, that's not safe to begin with. And so it's why that question is important to think about. And I'm just bringing up the chat to see if there was a question that sort of pop up, but I don't think there's one. Beth, if a question comes up, please let me know.
Will do.
All right. So the part of this presentation I'd like to spend the most time on is what we're about to do. And so to say that there's good news, there is evidence that medications can help. They're part of a toolbox. But we're going to look at NRT and pharmacotherapy, randomized controlled trials, specifically in adolescent population. And so as the table will demonstrate, so study is the name, participants, study type, the design, and then what was the outcome. And so for the purpose of simplifying this, we have patch trials, so nicotine patches. There's been several. And nicotine patches generally do show that they reduce cravings and withdrawal. So take home message from this is nicotine patches do reduce cravings and they do reduce withdrawal. Now, some studies show modest quit rates, and then others show no differences in the quit rate, but often there's a higher compliance, which means better engagement. And so patches should be recommended in the event that somebody is having a challenge of e-cigarette use. And so again, just really quickly, Hansen, NRT, and this was patches 12, 21, 14, 7. NRT should significantly reduce cravings and overall withdrawal. Molchan, the the patch had an abstinence rate of 18%, which is significantly higher than the placebo. Roddy, 4 weeks out, 5% of patch was abstinent versus just 2% placebo. And then Surshop, double abstinence rates after 2 weeks. This is the one that had no difference, although there was a higher compliance. So again, nicotine patches reduce cravings and withdrawal. In terms of studies about bupropion, so bupropion trial or Wellbutrin brand name. So we have 4 trials here, and bupropion take-home message shows modest benefit, especially at higher doses, so 300 milligrams, or combined with contingency management. So Killen in 04, there was no difference in the abstinent rate. Huber showed higher abstinence with bupropion and increased cumulative abstinence duration. Again, here they did 150. That's notable. And everyone got psychosocial intervention. Muramoto, so 6-week trial. This was interesting enough. Sustained release 150 versus 300 milligrams, and then it was just 7-day abstinence was their outcome looking at. And so placebo, 5.6%, the 150, 10%, but then the 300 was actually at 14% with a p interval below 0.05. And then Kevin Gray out of MUSC also looked at combining bupropion plus contingency management. That was superior in terms of abstinence rate versus just bupropion alone. But and then placebo plus contingency management. So this is notable because it is to indicate that contingency management by itself, in theory, does help some. But again, bupropion, and then here Kevin's study or Dr. Gray's study was using 300 milligrams also. So bupropion shows modest benefit, higher dose, particularly when combined with contingency management. And then we have
Dr. Simon, there are 2 questions about that if you wanted to answer them now.
Sorry.
No, no worries. They were just wondering if it maxes out at 300.
Oh, so
the benefit maxes at 300.
Got it. Sorry, Kate. It's a good question. I have to answer it based on what the trial showed. So within the trial, they stopped at 300. Now, in non-trial or in the real world, bupropion does technically go up to 450 or called 4 vivo. And I cannot say whether or not individuals would find additional benefit at the 450 because that's not what the study had looked at. However, within the adolescent population age ranges for a fair number of psychotropic medications, there is fairly regular off-label use. And so I'm thinking in the context of in the United States, thinking about FDA approval. And so we do have evidence from a trial that demonstrates 300. I don't have a trial that says 450. Yet if somebody were at 300 and found some benefit and in conversation with that young person as well as with the guardian, would they wanted to go to 450 because they needed additional coverage, or they were thinking about, is depression going to be improved, or is it that ADHD, because bupropion can be utilized second or third line for ADHD? It is possible to use 450 on someone that is below 18. And so, Shay, I think I just answered that question. And then Sarah, what is contingency management? So great question, Sarah. So contingency management, in essence, it's a fancy way to just say reward based. So you can think of in trials or in a home, someone might suggest if I'll give you a very good example that we often so within our program we have some young people who want to participate they participate in urine drug toxicology or urine tests. And some families will create a behavioral contract that says to the young person, if the quantitative value that is showing up, because we get quantitative numbers, not just yes or no, is it positive? So quantitative value on, we'll get cotinine. Cotinine is the breakdown product of nicotine. So quantitative value of the cotinine. And over time, if or every week, if the number's going down, the parent could then say, oh, you will get a reward at the end of the end of the week or the end of 2 weeks, or if they want to track it actually over the course of time, and the number is consistently going down, you're getting a benefit for demonstrating your willingness to participate in the trying to get the number down. And so in trials, contingency management might be coin based or it might be a ticket based. And so you can think of people will get access or rewards or points that can be turned in for something. So that's what contingency management is. And hopefully that was a clear explanation. Oh, thank you. Well, thank you. So yeah, so that's bupropion. And our next medication is varenicline, or Chantix is the brand name in America, or varenicline. And so we have two studies here. And so Kevin Gray, again from MUSC, and Evans from MGH, or Mass General Hospital. And so Dr. Gray's trial, 8 weeks, so 2 months, and varenicline reduced cigarettes engagement from 14 down to 0.1 per day. So within America, a pack of cigarettes is 20 cigarettes in a pack. And so varenicline was better at reducing the cigarettes per day than bupropion. Although bupropion, again, by itself actually went from 16 down to 3. But then Evans most recently published earlier this year, 261 youth, 16 to 25, so the age range that we're talking about, with daily or near daily vaping. Again, Dr. Graves was looking at traditional cigarette smoking. So nicotine vaping and 12 weeks of varenicline versus placebo with behavioral support. So placebo got behavioral support, varenicline got behavioral support. So 12 weeks, 3 months, continuous abstinence weeks, 9 to 12, so the back half of the trial. Varenicline was 51% versus placebo 14%. So odds ratio of 6.5. Remember that odds ratio number? You want that high. And so abstinence now 9 to 24 weeks out, varenicline was 28% versus placebo just 7%. And so this is to indicate that varenicline stands out in terms of, particularly for nicotine vaping and helping young people actually achieve abstinence and sustain the abstinence. Again, when paired with behavioral supports. And that behavioral support could be contingency management, behavioral support could be individual therapy, behavioral support also could be group therapy. So for instance, within our program, we provide all forms of behavioral support. So yes, there's psychiatric medication management or substance use management, but there's also individual, group, and sometimes even parent group, because again, you need to utilize all the tools in the toolbox. So thinking about clinical implications here, higher doses in terms of higher doses of bupropion, 300 showed modest effect for smoking cessation in adults. Varenicline demonstrates superior efficacy for both combustible tobacco and vaping cessation. Again, with Evans' recent study showing particularly robust for vaping. And then the patch is always beneficial. So in terms of what do our current guidelines actually suggest, and so I chose to look at the American Academy of Pediatrics as well as the Canadian Pediatric Society. And so for the AAP, it says consider NRT for moderate to heavy nicotine use for those aged 12 plus when behavioral interventions are insufficient. So I will make a point about this. And then for the Canadian Pediatric Society, it says consider NRT patch gum lozenge, but always in combination with behavioral strategies for youth with nicotine dependence or who are experiencing withdrawal symptoms from nicotine containing vaping product use. So one reads these two guidelines. Question becomes, well, what's moderate to heavy nicotine use? That's one. And then here you might then think, oh, what they're referencing patch gum lozenge. What about the medication? And so the way that we look at this, because when we think about so moderate to heavy nicotine use, unfortunately or fortunately, the data on what heavy use is often actually predicated off of like traditional cigarettes. And so, for instance, when we look at cotinine levels, so again, the urine toxicology, you don't actually, I mean, you could look at nicotine, but nicotine is so short-lived, it has a very short half-life. You want to end up looking at cotinine, the breakdown product. Cotinine, I can tell you that above a level of 200 correlates to like a pack per day. However, pack per day is traditional cigarette, not e-cigarettes. And so moderate to heavy nicotine use, you really do have to individualize this to the patient. Because again, if we're talking about a 12-year-old, well, any use is actually, one could argue any use is inappropriate. And if you're engaging with that vaping device once a day, once a week, but you're at the, in essence, near adolescent, pre-adolescent age range, that seems like that's heavy. And then simultaneously, you could have somebody who is a 17-year-old, and I would say once is very often. So we often look at timeline follow back. So it is true that you can ask young people how often they engage in timeline follow back, as we would call it in trials, is utilized, and evidence demonstrates that young people are actually pretty accurate. Even when we look at timeline follow back to the urine toxicology, they're pretty accurate. So take heed to what the young person is suggesting about their engagement with vaping devices. And so moderate to heavy, think about NRT. And then for the Canadian Society, perhaps as more evidence comes out, and I cannot remember actually right now the year that this came out, but it was not 2025. There's more data that we have, for instance, as the burn and clean. So it may be that the Canadian Society might modify or update, but does note if people are having withdrawal symptoms and demonstrating dependence, we should be thinking about NRT. So it is something worth considering. So in terms of the prescribing considerations, right? Medications are just a tool. And I tell families this all the time, despite the fact that, yes, I can prescribe, medications cannot be the only thing. There have to be utilization of behavioral tools, exercise, nutritious eating, sleeping arrangements, and so forth. So true, actual practical considerations. When we're thinking about the patch, and so there's 7 milligram, 14 milligram, 21 milligram. Depending on how often the young person is suggesting that they're engaging with the e-cigarette, you likely are going to either want to start at 14 or 21. And the idea here is to give a person, rather than having a spike of nicotine every time that they utilize their vaping device, the patch will then have a consistent amount of nicotine. And the patch has a protocol over time that you can go either from your 21 down to 14 down to 7, or from your 14 down to 7. And so I have found, and we have found evidence to show that, again, young people can benefit from the patch. Things to be cognizant of. So technically, patch has two types: 16-hour versus 24-hour. And 24-hour, keep it on the whole day. Something that regularly happens is people will engage or put on the patch, and they're anticipating that it's supposed to work like clockwork in terms of immediately. It's like, well, no, you need to keep it on. And those that actually keep it on over time recognize, okay, I don't feel the crash that might happen or the withdrawal that might happen. But some may be too impatient to go past the 1 hour or 2 hours, where they'll actually start to get the release over time. So that's something to be cognizant about, and make sure that they keep it on a clean area. In terms of the gum, so one of the challenges here is how young people, or how people, let me just say that, how people utilize the gum. So you'll recognize it says park and chew, park and chew. So you can start to use the gum, start to chew it. It's going to release a flavor, mint flavor, or whatever the flavor is associated with the gum. When that starts to happen, they actually should park it in their cheek. And then as the flavor dissipates, they can then chew it again to get the flavor release. And they can do that over the course of, so one piece of gum can be done that way for about 30 minutes, and then they would have to replace the gum. So you can't utilize the Nicorette gum the same way that they might utilize traditional chewing gum. And then the formulations in terms of bupropion, so there's an immediate release, sustained release, and extended release. The trials have looked at the sustained release. And so something here to be cognizant of. So sustained release classically has to be given twice daily. And you'll notice if in the best case scenario, somebody actually is getting it twice daily, technically that second dose, depending on when it's given, you might actually end up with a lower dose on the back end of the day than you would say with a one-time extended release. So the extended release versus the sustained release. And so sometimes what people do is, rather than increase the risk of someone missing a dose, they will say, you know what, let's just give the once daily. And again, this is where in the trials, you see the 300 milligram ended up yielding a little bit better effect. It's not described in the trial, but I suspect part of this is it's something that has to be done once a day rather than something that has to be done twice a day. So you just decrease pill burden, and so the 300 works out that way. And then the 450, for the person that asked that question, would also yield the same, because the 450 would be once a day. It's so hard to remember to park and not just chew. Yes, Kate, I would agree. So this is why you have to tell people not to just chew incessantly. And then in terms of varenicline, this is just showing the mechanism of action. And so, yes, nicotine hits the nicotinic receptor. Dopamine will be released. If there's nothing. But then if there's varenicline, or these yellow pieces that are partial agonists, when nicotine comes in, right, and so this is why you can have varenicline, the person may still attempt to use the e-cigarette, because there's occupancy on the nicotinic receptor, much less dopamine is released. And when less dopamine is released, there's less of a reward attachment to the vaping device. And so anecdotally, personally, I've seen patients be able to disengage from e-cigarettes with varenicline after trying other things within about a month and a half, to their own surprise. So those are some practical considerations to think about when you are with your young people. Can't be overstated, can't ever be stated enough. Motivational interviewing. So the principles here, it really key, because when young people engage with you, how we respond to them, how we come across to them, is as important as whatever, pharmacologic intervention that we might want to prescribe. So things like expressing empathy, truthfully expressing empathy. Express empathy towards teens to help build rapport, use reflective listening. So it sounds like you're frustrated with people you love telling you to stop smoking. The fact that you're aligning with them helps ease the tension. Now, in reference to that, really have to develop discrepancy between goals and current behavior, right? So just raising their awareness of their current behavior, helping them to identify differences between what they might have told you before or some goals and current behavior. So for instance, I've had young people, they engage in vaping, yet they also engage in playing a sport, and said, okay, so if you want to play in college or you want to make the varsity team, just help me understand how do those two things happen at the same time? Sure. In this example, says, I hear you enjoy smoking, and yet you're worried about your little sister will start too. What do you think are some ways to prevent that from happening? Avoiding arguing or confrontation. Now, I suspect that the avoiding the arguing part feels natural. Obviously, you don't want to argue with the patient. But the confrontation does not only mean like overt, I'm saying this thing that you're doing is bad. There's subtle ways in which we are confronting a person, and generally patients don't want to be confronted. And particularly for those that have substance use as a challenge, it's best to help reframe statements and then also acknowledge their ambivalence, right? We know stages of change. And so it says, I hear you that you're not ready to change your smoking behavior. What do you think would be helpful if and when you're ready to make the change? That might feel like a more neutral stance than saying something overtly, I thought you said you were going to, right? That actually is a confrontation. I thought you said you were going to. So trying to avoid that when engaging with the patient will be helpful. And then supporting their efficacy, right? So it's for the past successes, because they often will drop these things, such as, oh yeah, I stopped for a couple of weeks, last year. I'll actually probably praise that and say, oh, well, that's awesome. You were able to stop for 2 weeks or 1 month or 2 months. And so demonstrating that somebody is positively praising them about something that they did previously means that they likely could attempt to do it again or could achieve it again. So it says here, you were able to get in shape or make the soccer team. This is kind of the same. If it's okay with you, I can share some ideas that have worked for other people that might help. And we can also think about other ideas. You can do this. So affirm that the teen is able to choose and can carry out the personal change. And this happens also with medication management. Sometimes parents may join the session and imply that the medicines are doing the job. And I often reframe that to say, oh, no, he or she or they are the ones that make the decision every day to actually take the medication. So they are doing the due diligence and not placing a lot of the emphasis on the medication. And then supporting autonomy. So again, reinforcing that agency, that power chain lies within the team versus myself, colleague of mine, teacher, and then listen as the team develops an action list, steps to change. So it's like, you have some really great ideas about how to make some changes. We can continue to talk about those together as we figure it out. How will you do that? So these are the principles of MI, and really having these in your mind when you're engaging can be really helpful. Now, in terms of lived experience, sometimes hearing directly from families changes how we see the data that we were talking about. Because truthfully, behind every data point is an actual story, which is an actual teen or young person. And so this is an unsolicited letter that a mom had sent to our team not long ago. It says, "Hello all, 1 year ago today, we found out that he was having serious substance issues. Sat in the ER with him for 10 days as he cursed us out, refused to take his belt off, refused to pee, the list goes on. This morning, he is asleep upstairs. Came to school all week. We made cheesy potatoes together on a Thursday night for a school potluck. He's working regularly at Shake Shack and actually for the first time in a few years said the words, 'I love you' last week. I'm not being hyperbolic when I say I just don't think we'd be here if it weren't for you all. You are all amazing and have helped us navigate to what to me has felt like a totally insane nightmare. Dr. Simon, in particular, has very, very, very slowly and patiently taught me that he changing is as much about me changing. Took me a long time to figure it out and listen, but I think I'm on the right track. Thank you, thank you, thank you. And know that you are doing amazing work in this world. With gratitude, mom and dad." And for this family, one of the challenges in terms of the MI piece here, the young person, certainly I met them actually in the ER doing call on the weekend. And at one point in juncture, he had indicated, don't talk to me about X. I definitely won't do Y. And so I agreed. I said, hey, awesome, you're not going to do Y. Great. Well, let's keep meeting. And we literally meet. At this point, we don't meet weekly anymore. But we were meeting weekly, and there was no pharmacologic intervention at the time because he was not open to it. But we kept meeting. He kept showing up. And even when mom could try to surmise that something's happening, I said, no, he's showing up. That's good. When she'd be frustrated that a urine test was still positive for something, I said, but he gave the urine test. So let's praise that, right? Let's positively thank him for even participating because I have plenty of young people that don't participate. So there's always a way to reframe the engagement that is actually happening. And over time, he did eventually come to his own conclusion. Hey, doc, you said there was some medicine that might be helpful. I was like, oh, yes, I did. We've talked about that. And so at this point now, he is not engaging in any substances, not vaping, but that occurrence took time. And despite being prescriber, I could not predict the exact time that was going to occur, but I'm glad that it did. And we still engage and still go over. I still try to be thoughtful when engaging him and praising the things that he has done, not that I have done. So just sharing that because it can sometimes feel as though what we're doing, we don't know if we're going anywhere, but we are. So we are at the point where I'm gonna stop sharing and we're gonna open it up for questions, presuming that there are questions.
Yeah, there's actually one in the chat there.
Yes. Wondering about your opinion and experience with text messaging based vaping quit services for youth. So great question. I'm going to say it's Davin. And so any tool that a young person wants to engage with the idea that it's going to be helpful to them, I am pro for. Now, while saying that, if there's any nefarious things that happen because of a community or a group, obviously I'm not for that. But I've had young people come up to me and tell me that they're engaging in a new app and it's just impossible to keep up with as many apps as there are that they find helpful. And it's like, oh, okay, well, you're still coming to an appointment with me, you're still engaging in individual therapy, and you happen to be using some, additional service or tool. By all means, that's fine. But I can't speak to a specific app like I could, let's say, for sleep. And so if a young person finds a community that they find helpful, I think that that's fair. Um, just the same way that we would ask for different sets of substances, people to be engaged in group activities, right? It's the equivocal, just modernized for the sake of it's an app. And I think someone's putting a study in that
Yeah,
has.
I think it was the Evans study that you
Oh,
already referenced.
got.
Mhm. Awesome. Is there any other questions? I think we might have time for just one or maybe two. If you want to raise your hand or unmute, that's fine.
Oh, and I see Millen makes a comment. I don't think that this makes this first line, but it adds to the evidence. Yes, so generally we would strive as best as possible behavioral interventions to be the first line, right? So if someone comes to you and the parent or the guardian or the young person themselves is saying that they're struggling, it's important to be able to acknowledge that they could try to do a personal quit challenge or abstinence trial, but be mindful when you do this abstinence trial or quit trial, there may be things that happen like withdrawal. And so I might need to temporarily manage sleep. I might need to temporarily manage frustration that might happen because we know that's going to happen. So if you can alert the person to the fact that that's going to occur, um, that might also help them. And if the person is not keen on, for instance, pharmacologic options to help mitigate the withdrawal, there are natural ways to help attempt to mitigate withdrawal. They're not as effective as some of the pharmacologic options, but I'll give you two examples that were at the 259 mark in the East Coast. So lavender capsule, pharmacologic lavender is Silexan, Silexan. There's evidence for, and Calmate is the, I think, brand. There's evidence of one capsule or two capsules being efficacious as paroxetine, as well as efficacious as 0.5 of Ativan, and that's Silexan. So people tend not to oppose lavender capsule. Additionally, there's melatonin to help with sleep. But there are things that folks can attempt to do to try to help mitigate some of the withdrawal effects. Yeah, at least it should alert the person that that's likely to happen when if they try to quote unquote cold turkey it. Um, but yeah.
Awesome. Well, I think that's about all the time that we have. As you mentioned, it's near the hour. So we thank you so much for that presentation. I learned a lot. Just wanted to mention a couple of quick things. We do have a provider landing page that has a bunch of resources for folks looking for more things from Quit Now. We do have a conversation guide for working with young patients who would like to quit vaping as well. After this session, I will send a follow-up email with the link for today's court recording, a post-session survey, and any resources that were referenced today's session. So I just want to once again thank you so much for attending today and for your interest and attention to this topic. And so much, thank you so much again for Dr. Simon for agreeing to participate today. So look forward to seeing some of you again in the future if you come to another provider webinar. I really appreciate it and have a great day.